Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
All right, well, thank you. As Uvoh mentioned, my name is Jamal Flowers. Happy to be here, have the opportunity to present to you guys. Just a little bit of background. As you mentioned, I went to University of Michigan School of Dentistry. Clinic looked a little bit different than it does in the lower right at that time, but nonetheless, I had a great experience there. So go blue. I then went on to Harlem Hospital, did a general practice residency. That's when we got to do oral surgery, endodontics, all the specialties. First true clinical experience, and it was outstanding. So I definitely recommend a GPR if you get an opportunity to do that. It'll benefit you greatly. I then went on to do my specialty training at the University of Iowa, a 2-year certificate program in endodontics, and then went on to private practice in New York and now into Chicago, as he mentioned. Initially, when Uvoh asked me to talk, I wasn't exactly sure what I was going to talk about, so I just decided to go through what I do on a daily basis. So mostly I'll be focusing on non-surgical root canal treatment and non-surgical root canal retreatment. We also obviously can do surgical endodontics, apexification, apexogenesis, internal bleaching, and then the hot topic now is pulp regeneration. But as I stated, I'll focus more on non-surgical root canal treatment. And one of the things that I guess I try to focus on is not staying in the same lane and stepping out of the box and trying new things, especially if they've been proven and effective. And I'll get to that shortly, because I think one of the things we're doing is fairly new to the market, I'd say within the past couple of years, but it's been a game changer for our practice. Just a brief review. I know a lot of this stuff is things that we're already familiar with, but our biggest enemy with regards to endodontics is bacteria. And once bacteria does get into the system, then we have to get concerned about how it affects the tissues, where it goes from inflammation to necrosis. And then essentially it starts to disturb the periodontium, as you can see in these illustrations. So I'm going to go pretty quickly through what I do, and I want to focus more on the cleaning portion, and we'll get to that in just a few. But the biggest indicator for treatment for me is going to be my interview. I get a lot of information from the interview. We ask a number of questions, which is key, and essentially we can get the answer as to what exactly is the problem after just talking with the patient. Examination and testing is critical for every patient. We do an exam on every patient. We never assume we see what we see on the x-ray and go from there. We want to find out from ourselves and confirm the x-ray findings by doing our testing. So I'm percussing, I'm palpating, I'm probing. Every single tooth that I see, I've done that for, because it's also good for your own purposes from a diagnostic standpoint. You have a reference as to how the patient is when they return. Was it percussion sensitive at the time you did the treatment? Was there a crack that you observed? So anything that would alter your prognosis or what you expect to occur with that tooth moving forward. Tooth sloop is critical for patients that are clenching and grinding, especially what I've noticed in hard economic times. Oftentimes the go-to is to clench and grind for a lot of patients when stress is present, and then that manifests into cracked teeth and crack restoration. So something to keep an eye on moving forward when you have those pains of mastication. Again, selective anesthesia, transillumination, thermal testing, all these things that we use to come up with an ideal or adequate diagnosis for treatment. Typically, the two pulpal diagnoses we're going to see are the irreversible pulpitis, symptomatic and asymptomatic, and then the non-vital tooth or pulp necrosis. One thing that will help you if you have an opportunity to get to the American Association of Endodontists website, it's good to have an assessment as to kind of breaks down what to look for when you're selecting a case, what factors to consider, what may make it more challenging or less challenging, things you may not pay attention to initially on every radiograph, but something that you want to take key and to paying attention to. One example for me would be pulp chamber size. So it's easy to look at the root length and the shape of the tooth or the shape of the roots, but it's also critical when it comes time to access that we have an idea as to what we're going to fall into and what our goal is when we are doing our access. So pulp chamber size is key. You can see the tooth on the right would be much more challenging from a depth standpoint, and it's pretty far away from the occlusal table, whereas we probably would fall right into the pulp chamber with the tooth on the left. So things to watch for in your preoperative x-ray or preoperative radiograph before jumping right in. We just have to appreciate anatomy. I know we've seen a number of teeth, but you can look at the root morphology on these teeth and only imagine that the pulp system is going to be very complex for a number of these teeth. And that's something that we want to keep an eye on. We don't really have the methods to shape canals that have isthmus or fins. That can be very challenging. So we're going to have to rely on cleaning them, not necessarily shaping them. So just to give you an idea as to how complex some of these images can be. I think one of the things we get trained to when we initially look at root canals is that we're looking at a cylinder or an ideal taper, and it's rare to have the canals exist in that shape. You can see there's a lot of manifestations of these canals in different directions and shapes and sizes. So to dam or not to rubber dam, we rubber dam every case. That's considered the standard of care for root canal. So I will recommend you rubber dam as much as possible. I always put this little image up in these x-rays. I had a patient come in when I was in New York, and he asked if I was going to use a rubber dam, and I said yes, and he was ecstatic, and I'd never seen anybody really happy about that. But what he told me was he had a root canal maybe about 2 years before, and they dropped a broach, which is like this instrument you're seeing in the picture. A broach is a barbed instrument that's designed to remove tissue when you pull up against it. So it didn't go into his lungs, it ended up going into his stomach, and it got lodged in his colon. He was scheduled to have it removed, and about 2 weeks before his surgery, he had a very uncomfortable bowel movement, but he was much more pleased that it was out and didn't have to go through surgery. So just keep in mind the risks that we take when we don't use a rubber dam, and our prognosis of success is even higher when we do use it. So I would encourage you to use it as much as possible. A lot of adjuncts you can use as far as oral seal to help you keep the saliva out, but it also helps with visibility and patient comfort. So something to consider when we're looking at access. The radiograph is probably key. We want to make sure you're in the right orientation, you have the right depth, and then you get comfortable with the type of burrs that you're using. I typically almost always will use a round burr, but it's critical that we know where the anatomy is so we know what we're doing when we are accessing with a high-speed instrument. Maxilla versus mandibular is good to know what you're looking for, possibly the MB2 on the maxillary molar. It's good to know if you have one or two distal canals and where to look for them. A lot of ways you can assess anatomy before we get in, but we should already have an idea as to what to expect depending on what tooth we're looking at, whether it's a maxillary premolar or mandibular premolar. Have an idea as to percentages of how many canals should be present in those teeth. So one of the critical things to look at for the incisor is to know that we have an idea as to where the pulp horn should be. Typically, it's directly under the incisal edge, so that's something to watch for when you're doing your access. I also can cheat a little bit with a roadmap. If you have a mandibular molar, there's times where you maybe expose a portion or an orifice, and then you see a black line. Oftentimes, if you follow that black line, that's going to be a roadmap to the other canal. So something to look for is color changes as well when you're in the pulp chamber. That will help you to stay oriented and not over-prepare. We ought to make sure we completely deroof the chamber. That'll help us from an access standpoint and from a cleaning standpoint. So we don't leave tissue underneath those ledges or roofs. And it'll be easier for us to maintain. Avoid the procedural errors. That comes, like we talked about, with knowing depth and where we're trying to go, what our goal is and where we're trying to achieve. So one of the things that I was taught early is not to go deeper. Sometimes it's better to put the burr down and look lateral to see where you are, and even take a radiograph so you can stop. But going deep will usually create problems. So if you have an idea as to what the depth of the chamber is, whether it's 5 millimeters, 7 millimeters, have an idea as to how far that is on your handpiece or your burr, and then just make sure you make a mental note not to go past. So I typically will access to where I've assessed the pulp should be, and then I put the burr down and I'll look with the microscope or Endo Explorer and search for the orifice if I haven't seen it already. But I wouldn't suggest continually going deeper and deeper, because that'll definitely create more issues. Orientation is critical. We can't be fooled by the crown or the orientation of the crown if you are going through a crown. You can see how this tooth is angled because the 19 is missing, so 18 is mesioverted. And if we were to access, we want to make sure that when we do access, we're accessing in the right plane so that we can achieve our goal of reaching the pulp tissue. Again, it shows you how the incisal edge, or you can see, have an idea as to where the canals will be on an incisor, and how we can over-prepare or over-instrument looking for the canals. Okay, shaping. So the purpose of shaping for us is really just to make a pathway for our irrigant. We're really just trying to shape so we can get our sodium hypochlorite to as close to the apex as we can safely, without binding and without extruding any solutions and creating an accident. But that's really the main goal of shaping. There's many orifice shapers that people use. I typically use the SX, which is that picture on the left. That's a Dentsply rotary instrument. I use that for orifice shaping. I used to use Gates Gliddens all the time, but then I moved to the rotary just because it was easier and I could see better. I always use hand files, even till this day. There's rarely a case I won't use a hand file for. I think that's critical if we're talking about using rotaries. I think it's definitely necessary that you've used hand filing up to a certain size. Usually for me, it's about a 20, they're O2 tapers. All the hand files are O2 tapers. So typically the ISO sizes, at least, I'll use that up to about a 20 before I put a rotary into the canal space. Apex locators I use often just to confirm my length. I always verify it with a radiograph, but it's good to at least have an idea as to how long it is and where to shape, what length to shape to. Nickel titanium is great. It's been a great game changer for us as far as the endodontic community goes. It's saved a lot of time for patients as well, and I think it makes the appointment a little bit more comfortable for the patient. We have multiple canal types we've talked about, or you've seen. The S-curve is a critical one. That's something you want to look for on your mandibular molars or even maxillary premolars, because that can create some challenges when it comes time to cleaning and shaping. Locate all the orifices. Passive hand filing is what I'll do. I'll open up the orifice, and then I'll use the apex locator to get my length. Once I have my length, I'll use stainless steel hand files to shape that length passively. I'm not very aggressive. I'm just really trying to get to length. And then I'll introduce the rotary endodontics. Typically right now, what I've been using is the Edge Endo files. I like that file a lot. It's pretty durable. It's much cheaper than the other files. It was created by an endodontist. So if you do have an opportunity, I would look into those files and see how they work for you. But there's many different types of file systems on the market, and I just would encourage you to try different ones and see what will work best for you. They all have different features, and they can be very effective. Something I'll use for almost every case that I do, I'll take a three-dimensional image, a computed tomography CT scan, cone beam computed tomography scan of every tooth. The ones I may not would be a maxillary incisor. About 100% of the time, they usually have one canal, but if the anatomy looks different or if there's suspicions of resorption, then I'll almost always take a scan. But for the most of the time, I'm going to take a three-dimensional scan of the tooth before I do any treatment on that tooth. A dental microscope is what we use for every single patient as well. It's not just magnification, but it's also illumination. So we can see really well with the light that's in there. So it's easier for us to locate extra canals or canals within a crown So it's imperative if you have the opportunity to use it, I would try it out just to see the differences. C-files, endo activator, chlorhexidine, the Journal of Endodontics, all of these are things that are used to help improve our case selection and our prognosis pretty routinely. So why do we use nickel titanium? Why do we use that metal? It's very flexible. It has high elasticity. It's typically fracture resistant, but it can break depending on how we use that instrument. And the bending cycles are phenomenal. So some of these you can really pre-bend before even entering the canal space. The differences a lot of times are in the metal that they use and how they're designed, or how many flutes they have and the direction of the flutes. And this just shows you a little bit of the differences between the different files. I used to use Vortex Blue routinely. Now, like I said, I use the Edge file, but sometimes when the helical flutes are closer together, it's more flexible. So a lot of times you'll see a lot of flexibility just in the tip. With the Edge files I'm using, I have the flexibility in the tip, but also higher up near the handle. So that's one of the other benefits I like of the Edge Endo file. So I can pre-bend it. I typically use 04, but I'll show you a little bit. I'm sorry I'm going really fast. I just want to get to the other stuff. But I'll show you how I used to shape versus how I used to shape versus how I do now. My previous cleaning protocol, I was using the vented tips, the vented ports, which is critical. The advantage of this is you're not pushing the fluid in an apical direction. You're pushing it to the side, so you have less chance of binding when you use a tip that has a flute as such. But it's critical, though. Obviously, the length or how far we can get that probe into the tooth will determine how effective we are at cleaning, and I'll show you a video on that shortly. These tips can be good. I've tried these tips a number of times. They have the double vent, but to me they're a little bit fragile, so you have to be careful when you're using this, because sometimes it'll bend or break at that point if you bump one of the walls. So just be careful when you're using any of the tips. Endo activator can be effective for some. I don't use this anymore, but I used to use it to activate the solution. But you just have to be, if you do use it, you don't want to touch the walls, because it'll dampen the displacement amplitude, and that's where you get the cavitation or the bubbles to form. The bubbles are what break down and break the tissues down. So if it's hitting one of the walls, it's probably not as effective, but it is on the market, and many people are using it. My new cleaning protocol. So this is really what I wanted to get into today. I've been using a system called Gentle Wave, and Gentle Wave is a unique cleaning system that's used. There's a machine that you would purchase that stands up in the office, and you can move it from room to room, or you can have multiple machines. And I'll walk you through it. But there's a lot of literature to support it and its use. The key, though, is to really target these areas that we have a difficult time cleaning with hand instruments and with sodium hypochlorite, at least how we've been doing it. The purpose of this, like we talked about earlier, we're trying to get rid of the tissues that have been damaged by the bacteria. So our goal is to clean all of this out. We want all of this area in black to come out, because that's typically where the bacteria is, and that's what's causing the damage to the surrounding periodontium. What we're taught is to drill and fill, basically. We clean and shape. It's not what you put in, it's what you take out. So it's not necessarily the gutta percha that you get into it. It's all the tissues that are damaged that we're removing, and that's our goal. We're using sodium hypochlorite not to only disinfect, but to also break down the tissues. That's why we're using sodium hypochlorite. That's why it's our solution of choice. There are other solutions, but there's not a solution that does both. There's some that will disinfect, and there's some that may dissolve, but this one does both. So it's been very effective for us in the endodontic community. So our purpose of shaping, like I was touching on before, is irrigation. That's the reason we're shaping. So initially, if you wanted to get a 30 gauge down there, it's going to be on a curved root. You're going to have to shape that canal pretty wide. And typically how we've been shaping, in order to get your apical large, you're going to have to shape the coronal really large. And then we may straighten out the curves, or we may get into strip perforations or making the walls very thin. This instrument or this mechanism is giving us an opportunity to conserve dentin. That's really what I like most about it. I don't have to be really aggressive with my shaping in order to get this syringe needle to get to the apex. If we have a let's say it's a moderate curve, I'm sorry, if we had a moderate curve, it's very difficult to get your irrigation syringe to the end of the canal space to clean effectively. So many times we're just cleaning where the tip is. You may work in a wet environment. That's how I was taught, meaning have a pool of the solution into the chamber and into the canals, but you're not actually pulling the solution down to this area. The solution is only cleaning or disinfecting where the needle tip extends. So you can imagine how tough it would be in these curvatures to get our irrigation solutions to the end. So why did I transition? I was having issues with one of the instruments I was using was separating, and I talked with the manufacturer. They couldn't tell me what it was. They had heard some other people were having issues. So I just got tired of using certain rotary instruments, and I wanted to be very conservative with what I was doing. I felt I was seeing a lot of crack teeth because for a while when I first started working, I was doing all 06 taper almost pretty routinely for every tooth. So then I switched to using 04 taper, so I wasn't removing as much dentin. Now I'm shaping to a 2004 or even a 2504 in some cases, and that's the largest that I'll shape the canal. But am I debriding effectively? So these are some of the older cases I have. You can see the taper is much larger in many of these. This is 06 taper, probably a 35 or 3006 for many of these, maybe 4006, depending on if it's the palatal canal. And then this is how it looks now. This is how I'm shaping now. So these are 20 and 2504 canal shaped. And honestly, as endo, you know, we're judged by the radiograph. So you want your radiographs to look nice, but you also want to still focus on the same goals we have in mind as far as achieving patency to the apex and cleaning the system out effectively. So this is what the system looks like, the General Wave system. It's a console that you can wheel around. You see there's a handpiece here. That's the handpiece will connect to the tooth. There's two types of handpieces. You have an APM, which is the anterior or premolar handpiece, and then you have the molar instrument. So the difference in the two is this one has a lot of the mechanism inside of the handpiece. This one is outside of the handpiece. So what you'll do is you'll attach a cap right onto this piece that will limit your depth, or the depth that you place this probe right here. So this probe will end up about 1 millimeter from the floor of the pulp chamber, and that's what we want to do. There's a bunch of gaskets and tubes and containers of solutions inside of this system. But the purpose of it is to optimize fluids. So we're using the same fluids that we've always used, or that I've always used when I clean. It's sodium hypochlorite and EDTA. So we're still cleaning effectively. We're just running it through this system. So this is what you'll typically do is you'll use a sound seal to create a barrier. You just light cure, it's like a resin almost. You just light cure it. It's going to be a platform, and then we'll create a seal that this handpiece can rest directly on. We don't want any solutions to escape this seal. Now keep in mind, you still will have the rubber dam in place. So you have a clamp here, but this will bond really well to the rubber dam and help us to the rubber dam clamp or retainer, and that will help us to get a good seal. And then it's going to run the solutions through this system. So the way this works, you can see these arrows. That's kind of the movement that we're seeing in the fluid. So if you look at this whole system is filled with fluid. There's no air in this system. The whole system is filled with fluid. And what this is doing, what the General Wave system is doing, is using sodium hypochlorite for a cycle, and then it will run water for a cycle, and then it's going to run EDTA for a cycle, and then it will run water again for the cycle. What it's also doing is degassing these solutions. It's degassing the solutions so they don't bubble up in the system. We don't want any bubbles into this system. So they take all the gas out of this through this mechanism. You can see the arrow or the flow of the fluid. It's shot through this probe here, and then it comes up back out of these export portals here. So how it works, this is the molar one, this is the anterior one. And basically, it's advanced fluid dynamics, like they're saying, and we've degassed it. So this shows you how water, the phases of water, this is typically the region we're on if we just have ice water, but it works, room temperature water, and it works through cavitation. So what it's doing is sending, it's decreasing the pressure from the handpiece. It'll drop the pressure down. When it does that, it creates a water vapor really quick that creates a bubble. So when we change this pressure, we're creating a small water bubble, which is cavitation. That bubble will then collapse. That collapse of that bubble is what breaks the tissues down, and it creates a sonic wave or a shock wave through the fluid. So when it hits, go back here. When it hits this platform, so the solutions, sodium hypochlorite, we'll say is the first solution, is shot through this chamber here. There's a plate here. When it hits this plate, you see these two arrows. That's the fluid branching off. These are the cavitation bubbles that are created, okay? These cavitation bubbles will essentially collapse. When they collapse, they're sending waves throughout this system. It's similar to when I showed you that endo activator. You're activating the solution by creating those little cavitation bubbles. So when that's activated, that accelerates the science of the sodium hypochlorite to break down these tissues. So those tissues are broken down at an even higher rate than what we've done before. What you'll see when we use it is that this is just showing you the fluid getting shot down into the plate, and you can see this is where you see the cavitation bubbles if we were to look closely in it. So that's the key to success, is the activation of the solution. We're still using sodium hypochlorite, but we're making the sodium hypochlorite more aggressive. So there's two ways essentially that we're breaking the tissue down and cleaning the system. The first one, as I mentioned, is those cavitation bubbles. So these bubbles are creating these waves. These waves are going into these accessory canals, into these fins, into these isthmus that we can't clean mechanically in the past, or that we've tried and haven't been too successful with. But it's cleaning all of these out, and we let this system run. It runs for about a 7 minute. It'll add about 7 minutes of treatment time to the procedure. But the time I'm adding there, I'm also taking away from shaping, because I'm not shaping to a 30, 35, 40 anymore. As I mentioned, I'm shaping to a 20 or a 25. So I'm using maybe two or three rotary instruments as opposed to 4, 5, 6 rotary instruments that we may have had to use in the past. So the first mechanism of cleaning, as I mentioned, is just those cavitation bubbles that are creating these waves, and they're breaking those tissues down. But what this plate does is the fluid hits this plate, and it comes off at a 45-degree angle. When it comes off at that 45-degree angle, it creates these circles or vortexes in the solution. So if you look closely, this is kind of like a circular motion. It's almost like a tornado. It's actually activating the solutions all the way down to the apex, but it's creating a negative pressure system because it's pulling these tissues back out. So that's how we get the turnover of our solution. The solution comes in, it's activated, it's swirling, it's creating these vortexes, and it's pulling this tissue back, this solutions and the byproducts back out here, and then more solution is coming in. So it's firing off at a pretty high rate, but that's why it's so important to have a good seal, and that's why it's important that's why it's important for these solutions to be degassed, so that bubbles won't interfere with the flow of these shock waves. So once this is all cleaned out and disinfected, then we're in a much better position to operate, in my opinion. So this is just showing you a schematic of how strong that force is that's being fired into the tooth. So you can see it comes at a pretty high volume. If I was to hold it up and this plate wasn't there, it would probably shoot across the room. It's a pretty high pressure solution. So this is just a video showing you the needle irrigation. What I wanted you to pay attention to in this video is you can see the needle, but the solution is like glycerin. This is just blue glycerin, but it's only cleaning where the needle tip is. If our needle tip doesn't make it down here, we're cleaning here. So just to show you again, just so you have an idea, it's very important if we are using the needle, we want our needle to go pretty far down without binding so that we can irrigate effectively. This is the endo activator. That's the system I was telling you about before. That white is vibrating, but if you can see, if it's touching the wall up here, it's not vibrating as much as it was. But this is going all the way to the apex, but it's not really clearing the glycerin out. Primarily because it's getting dampened by these walls here. So it's not vibrating effectively like we want to the end in this scenario. And so if we look at gentle wave, it's tough to see that it's running. If you look close, see if you can see some of the action here, see a little bit of the bubbles and whatnot moving, but we let that run. It's slowly going to get this out. Slowly going to pull these areas out and get the glycerin out. This is after those other tools have done it, after the other instrumentation with the needle and the endo activator. So you see activity around in that area. This is just showing you that we have the activation or the bubbles. You can see the movement of those sonic waves breaking these tissues down in areas that we wouldn't have been able to clean this on our own. This is an accessory canal on the side. So you can see how effective it's cleaned a lot of this glycerin or a lot of this blue dye out. And granted, that's not tissue, this is just glycerin. Instead of using just dyed water, they use this example of glycerin to try to slow the process down just so you can see it. If it was just water, it would be turned over really quickly. So this is just a schematic just to give you an idea as to where the gentle wave is working and what it's doing. We talked about the degassing and why it's effective. Or why it's important. But the one on the left was not degassed and the one on the right is. But these bubbles will interfere with the ability. It will still work, but just not as effective as it would without the gas, without the bubbles in place. So you can see this whole system is being activated, whereas these bubbles are holding up or delaying our ability to clean those areas effectively. Again, same thing. This is just the general wave running. Again, they use glycerin just to give you an idea as to where it's working and what it's cleaning. So I'll try to wrap it up. I know we don't have a lot of time. I wanted to show you. So that's just water in the green. That's not the glycerin, but you can see how fast it was able to clean that out. I wanted to show you, there's a video. Number of articles that will support the safety of the use of this. This video is interesting to me. So there's green, they're cleaning this out with a hand file. They're going to extrude the hand file, so at least you can see that the apex is open. And they'll run gentle wave, and you'll see there's green dye in here. None of the dye will come out of the tooth when they run this machine, which I think is impressive. This just shows you, when we talked about the vortexes that are created in the solution, this shows you how they're pulling the solutions back, which is what you. So instead of extruding it, we're pulling the solution back. So you can see they're running the machine with green fluid instead of sodium hypochlorite throughout the system. So you can see a little bit of the green going into the canal spaces, but it's not coming out of the tooth. And they've already opened the apex, so we know the apex is open. But because of the negative pressure and the way that the system works, it's not allowing any of the solutions to be extruded. which would be a concern for anybody who's using sodium hypochlorite. But you can see it's done safely. So now they're going to show you the file, go back into do with the green dye in, and this is the irrigation. You can see it's being forced out with an irrigation tip. So that's interesting because it does allow you can be a little bit anxious when you initially use the machine, but you can trust the machine in these scenarios. This is just a comparison of activating solution with GenWave versus on the left, they're using just the needle syringe. And you can see over time, the one on the right will break down significantly faster. You can still use hypochlorite effectively the way we've been doing it, but we're hitting the solution, we're hitting the tissues much more aggressively and with much more solution when we use the GenWave. So I'll skip this in the interest of time. This is just giving you an idea as to what the motion looks like with the solution when it's inside of the tooth. So a lot of literature to support the dissolution of the tissues. This was a study done by Molina, and it just compares some H&E stains of not instrumenting and then instrumenting with rotary and irrigation. And the difference, I think, was around 66 or 68% of the tissue was removed when we used rotary and irrigation. And in the GenWave, it was 97%. So what this has on prognosis, I don't know definitively, but I do know I feel better about getting the tissue out. As much as I can get out, I would like to. So that's the benefit. When you look at these cases, it's almost pristine. When you're done rinsing with the GenWave, the canal space is very clean. You can see a noticeable difference when I compare it to cases I've used without GenWave. So these are just some of the views you'll have once we're done with the cycle before we obturate. And then obturation. So I used a lot of sealer, more sealer than I used in the past. And I'm using a bioceramic sealer, which is comfortable for the body. So I'm okay if I do extrude some, but you can see how easy it is to get into these accessory canals. The difference between these accessory canals or seeing sealer puffs on the side now versus how I did it before GenWave. I think the difference was before I wasn't cleaning these canals out. Now I feel comfortable that the tissue has been removed. I'm not just pushing sludge out of the canal spaces into the PDL. I'm actually cleaning it, and then the sealer is entering into those spaces. So it's just a better feel from an obturation standpoint. So this is just showing you some of the voids we can see in the way we've done it in the past, and you know, this is how I was doing it before. And then this is what GenWave will look like in a cross section, about 3 or 4 millimeters from the apex. You still have better aperture, but you have good sealer as well. So we're relying on the sealer to do what we expected it to do before, but we've also cleaned these areas. There's not debris in these areas like there may have been in the past, especially closer to the apex without our syringe reaching the apex. Now we know these areas are cleaned. So oftentimes in some of these cases, you're going to see the sealer go in many different areas, and that's just showing you those areas have been cleaned out. So that makes you feel a little bit better too about the prognosis if we know there's lesions in those areas. These are just a couple of cases that I did. You can't really see what the anatomy was like on this tooth, even with the cone beam. It was tough to see exactly how many canals were there, but you can see where the sealer went, and this is gutta percha, but this is sealer here, 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 here. So a lot of these areas are still filled in, and I feel comfortable about that because they've been cleaned out. This is just showing you some images of teeth that have been obturated after GenWave and after obturation. So you can see how they filled these areas that we probably wouldn't have been able to get access to without using a system like that in the past. So just things to consider when we're looking at cleaning and shaping. I had some, how are we on time, Uvoh?
Good, you're good.
Okay. I want to show you some more, just some cases. This is just showing success rates. There's a number of articles you can look up on GenWave that will help you. These are just a number of the ways to obturate. I simply just still use a warm vertical. When I use warm vertical, I'm using System B most of the time, and I use any one of these techniques to backfill. I think they're all good. I use a Buchanan plugger because has a NiTi tip, nickel titanium tip, so I can go around curves and condense the gutta percha as needed. And then I just backfill with those like we talked about and express the sealer. I don't use the core-based gutta percha, but it's been shown to be effective for some. If you are using, I would recommend the gutta core. I think the thermophils are the ones we see. They look good on the X-ray, but I've seen a lot of those fail even when they look good. So this may be an option for you if you guys are using core-based gutta percha. So just more cases. So the cone beam. What I like about the cone beam, and this is what I'll finish up on, just giving you an idea as to the benefits of what we use it for. We have three planes we're looking at: the axial, the coronal, and the sagittal view. When we're looking at different scans, the axial is pretty critical for us when it comes to looking at canals or trying to determine how many canals are present in the system. So this was a case, when we look straight on, it almost looks as if the post is not in line with the gutta percha. You can see the lesion here, but it's tough to determine exactly the dimensions of this lesion. So we took a cone beam of this tooth, and you can see that the post is actually near perforation or perforating through the facial. Our lesion comes down in that direction, giving us an idea as to where our issue lies. So instead of trying to repair that communication and do the surgery, the patient elected to have the tooth removed and an implant was placed. So this tooth, what we relied on in the past was the buccal object rule or the slob rule to determine how many canals were in a tooth. Many times we know about close to 90% of the time there's probably a second canal in this mesial-buccal root of a first maxillary molar. So you can see on the X-ray that the canal was missed. If the canal is centered, then usually there's just one canal in the root. And you can see here we're off center here. We're much closer to this wall than we are to this wall. So even if I don't see the actual canal space on the CT scan, I know to look for it when I know that this is oriented more towards the facial. So we rely on that to we go ahead and find the second canal and redo the root canal. So this tooth had a surgery. I had apical surgery 9 and 10. The patient was asymptomatic. There was no swelling, no sinus tract. You see a unique formation of bone loss here. And it doesn't necessarily look like it's adjacent to tooth number 9, more so with 10. But when we took the scan, you can see how involved or how large this lesion was. What we were seeing, those two spots, were the areas where it violated the buccal and the lingual cortical plate. So typically for us, we'll see a defect when it violates the cortical plate. It's a lot more obvious, but if it's doing both, then it's going to look really radiolucent. And you can see from the sagittal view or how aggressive that this lesion has been in those areas. And this is a view of the 3D rendering from the palatal. So this patient was referred for a retreat of 18. They saw a sinus tract near the apical of 19 and assumed that the problem was coming from 18. But when we did our evaluation, you could see the tooth number 20 has a lesion, a pretty decent sized lesion, but it also has a resorptive defect at the end. And it wasn't too obvious. I mean, hindsight, when we go back, we may see something here, but nothing I would have definitely assumed was there when I saw the periapical imaging. So that's the benefit of the CT, offering us other angles and other views. And axial view, you can see how aggressive this defect is. So even though we have space in this direction, it's going to be very difficult to fill adequately to make it look like we may want it to look on the X-ray. I'm more so trying to clean this area out up to this defect to see what type of resolution we can get. So we filled it to that defect, and then we just wait for the recall. Root canal was rendered by their general dentist. They referred to me because they were having issues in the sinus, congestion, mild ache, no swelling. So we took our scan. It's just extrusion of material, extensive material. that was into the maxillary sinus. You can see it pooling over here and over here. So we didn't do treatment. We've just been monitoring to see if the symptoms resolve. So same thing with the MB2, untreated MB2, that we can see on the scan, the axial view. Even from the coronal view, you can see, we look at the position of the canal. If it's centered, then there's one, but you can see this is much closer to this buccal wall than it is to the lingual, so we just assume that there's a second canal, present in that tooth, and you can see on the retreat, we're able to locate it in an instrument and remove the post. I think this is my last case. So again, the advantages of the cone beam is we can see a different view of this tooth. Typically for us, when we have vertical root fractures, they're vertical, as we said, but they're almost always in a buccal lingual direction. So initially when I was in school, we learned that there was a sinus tract. We learned there was an isolated probing depth on those teeth that have vertical root fractures. But I think that's only present about 60 to 66% of the times. I don't oftentimes get an isolated probing depth. What I'm looking at is the pattern of bone loss. I'm not looking for the actual fracture on the scan. I'm looking for the pattern of bone loss. So if we know what happens in a buccal or lingual direction, I'm looking to see if the defect is just at the apex or if it travels along the buccal surface or along the lingual surface of the tooth. That's how I diagnose a vertical root fracture. So it's not just the sinus tract or the isolated probing depth. Many times for the vertical root fracture, we're going to have a sinus tract, but what I noticed with the sinus tract is much closer to the free-gingival margin than the apex. So that's another sign of things to look for. And then if our lesion is violating the buccal or lingual cortical plate, then we'll have an idea. So this is the same tooth. You can see the lesion here, but we also have lost bone along this entire surface. And I'm not expecting to actually see the fracture line on the tooth, but this is classic enough for me to determine this tooth has a poor prognosis. You can see how wide this has been shaped, possibly because of the age of the patient at the time of trauma, but this tooth definitely has a poor prognosis. We wouldn't recommend treatment on that tooth. As far as the future of endodontics, I think our direction is to try to continue to conserve dentin, multisonic ultra cleaning, which is what the general wave is. Pulpal regeneration is a big topic now to try to preserve teeth. And then guided tissue regeneration. Hopefully down the line, we'll see something soon with tissue engineering. So thank you for your time. Be more than happy to answer any questions. I will stop sharing and get out of the way.
All right. Thank you so much, Dr. Flowers. That was amazing. Do you use a microscope?
Yes. Every case we use a microscope.
All right. And you have a CBCT in your office?
Yes.
I mean, what would you advise? Go ahead.
Go ahead. I work with a periodontist. He was a classmate of mine at University of Michigan. So we ended up getting a Carestream 9300 at the time. We just got a new, I think it's the 9800, because it had different fields of view. So I just used the 5x5 high definition field of view for endo, but with perio they need multiple different views. So
okay.
that machine worked for us. But there's many of the machines I've seen are phenomenal. So I'm not partial to any of the machines. I just know that one works for us. Okay.
I mean, if you have a question, please, if you want to speak, just raise your hand. I'm going to pick on someone here. I know you did not say, but I want to call on Dr. Okaichi. You are able to speak if you can unmute. What is your experience with it? What kind of endo do we do right now? Go ahead, sir. Dr. Uchenna?
Okay, thank you. Really, I'm into maxillofacial surgery.
Okay.
So, but my experience. Hello?
Yeah, go ahead. I can hear you.
Hello?
Go ahead. I can hear you.
Can you hear me?
I think your internet.
Okay.
All right.
Yeah. I said I'm into maxillofacial surgery right now.
Okay, okay, no problem.
Hello?
All right, no problem. Your internet is a little
Hello,
bad.
can you hear me?
Can you type in what you just want to say? Your internet is not very, the connection is not very good. Dr. Macey, can you hear me?
Hello, Dr. Uvoh.
Yes.
How are you?
I'm fine, thank you. Can you make a comment as to how is where are we in Endo in your institution?
Okay, great. Here in Lagos, at the University of Lagos and the Lagos University Teaching Hospital, we have started doing rotary endo for a bit now. And the system we use basically is a pro taper. And here also, I think some people have started using the reciproc system. So yeah, we are into rotary endo presently.
Okay.
Quite a number of people. CBCT, we haven't quite gotten around to that, at least in my center. We're hoping to move up to using CBCT, hopefully, pretty soon. I think that's one system we would like to have in our place.
Okay.
It would also be nice to try out some of the systems Dr. Jamal has talked about. I think those ones really look nice.
Yes. Yeah. Yes, I mean, hopefully we can. I mean, I like this series because it takes us to the future. It lives, because we are definitely going forward. And someone is asking. Thank you so much, Dr. Macey, for your comment.
You.
Dr. Shade Akiode, are you there? You are able to speak if you want to. I just wanted to make, if you have any comments. Well, but there's a question here about. Did you see the question? Okay. Yes, you answered. All right. Okay. All right. That's good. Well, but for the interest of others, there's a question here that says, what do you think about wave one?
That's the reciprocity nickel titanium. I think it's effective. I think all of the rotary systems are effective if you use it. If you use the same protocol, my opinion, if you use the same protocol every time, meaning use your hand files to establish your glide path to an ideal length, the ideal working length that you're trying to achieve before you use the rotary. I wouldn't just jump right into rotary. I wouldn't use rotary to open things up other than the orifice opener. So typically for me, I'll use the orifice opener and then I get my working length and then I'm hand filing, preferably to a 20 before I would introduce rotary. That's probably the safest way to reduce the risk of you fracturing or separating an instrument, a rotary instrument, because they will separate. So it's engine driven. So it's the wave one, I believe, is reciprocating, but they're engine driven. So if the tip of it binds, if you haven't opened it up enough and the tip binds, the engine's still going to drive that instrument. So it can separate, and they're not as easy to remove as they mentioned many times. I have a hard time removing separated instruments, and it takes a lot of time. So if I'm going to use a rotary system, I'll make sure that I use a lot of irrigation, and I check the file after each use. So once you use it, you're not pressing on the file. You enter the file into the canal. Every time I take it out of the canal, I would wipe it off, because if you have debris in those flutes, there's nowhere for that debris to go when you add more debris to it, and that locks the file as well and can cause it to separate. So the key to using rotary is a lot of irrigation and a lot of cleaning, and inspect your file, because if it unwinds, that's a sign that it's going to probably break. So after each pass of my rotary instrument, I'm wiping it off and I'm checking it.
Okay. Can you just answer for the benefit of those who are not able to read this? There's a question about nickel titanium file indicator for curved canals. You did respond. If you would just elaborate.
Yes, same thing. I was just saying, I think any of the systems will be effective. What I was saying in that, once you have your desired working length, I would use your hand files up to a 20 before introducing the rotary. But I wouldn't be against using it depending on the curve. I think they're great for curves. I think nickel titanium is great. That's the huge benefit of nickel titanium. A lot of these files now are designed to stay centered in the canal, so you have less chance of transporting, less chance of removing the portions of the dentin that you don't want to remove, and maintaining the curve. So I think there's advantages to using rotary and curved canals. However, You just have to try to establish patency first as opposed to establishing patency with the rotary instrument.
Okay. Dr. Namboya, can you hear me? You are able to speak if you want to. Do you have any comments? Okay. If you are there, Dr. Naboya, yeah, Maria, Dr. Naboya, that's my teacher from military hospital in.
Oh, nice.
Anyway, if you're able to hear me and you want to make a comment, please go ahead. Dr. Aaron Tamrat, you are from Ethiopia. What is your experience? Aaron, if you want to say something, you can go ahead. But anyway, next weekend, we're going to have Dr. Mazen Sultan. He'll be speaking on the complications of implant therapy. And on the 27th, we're going to have Dr. Brian Goodacre. Anything about digital dentistry, this is the man to talk to. In the USA, he's in any major conference. Dr. Brian Goodacre shows up there. So, I mean, this is where we're going. If you want to learn something, let's come up on the 27th of September with Dr. Brian Goodacre. It's going to be on a Sunday, and we're going to have Dr. Mazen Sultan is going to be speaking on the complications of implant dentistry. If there, let me see, any more questions? Let's see. Can you comment, Moses Ishagi? Can you comment on, is it pulpotomy or what were you trying to say? Pulpotech? Dr. Jamal, are you familiar with that term?
No, I'm not. I think it's a product. I'm not aware of that product.
Okay.
I just was looking it up. It says it's a radiopaque, non-resorbable filling paste composed of powder and liquid. Yeah, but it looks like the liquid has formaldehyde. So I wouldn't use anything. My opinion, I wouldn't use anything with formaldehyde.
Okay. There's a question here. Endo technique handpiece also helps to navigate partially. Are you familiar with the Endo technique handpiece that helps to navigate partially blocked canals?
So what's the name of it? I'm sorry.
Endo technique handpiece.
Endo technique that helps to negotiate canals?
Yes.
No, I don't utilize it. If it's effective, I mean, if it works.
Okay.
I do see a question about.
Okay, Dr. Naboya is asking, say, which is your most used rotary file? I mean, so do you still do rotary?
Yeah, so I use the SX, which is the Pro Taper Orifice Shaper, and then I use Edge, the X7 series. I use the 15 size, the 20, and sometimes the 25. Okay,
so Edge Endo it's a good product.
Yes, I like it.
Yeah. So when you do with your Edge, do you use the reciprocal? So I know your filling methods. You do the backfill, right? Instead of okay. Yes. But I know they do have some of these systems. I use Cyber Endo where they have.
So what Edge did though, Edge they essentially a lot of their files mimic the files that are on the market. So once the patent is worn out, many times Edge will make a very similar product that, from my opinion, has been just as effective.
Okay.
So they tend to be cheaper than the big name files.
I see.
But they're picking up momentum. So it's worth looking into. A lot of the files that you're using, you may be able to find something similar, and they'll say that on the website, similar to the sequence or whatever file you're interested in. So check that out if you get an opportunity. I saw there was another question about option between surgical endodontics and extraction with implant placement, which in your opinion will offer more peace of mind to patients. I think it's tough to say. I think one of the advantages of the surgery, I have some patients that are really pleased with the aesthetics of their crown. So say, for instance, it's an anterior tooth that's had trauma and the root canal is just not doing what we want it to do. Those, I think, are really good for, surgery is really good for those patients, I believe, when we talk about peace of mind, because they don't have to disturb anything aesthetically. It's a little more invasive, but we do surgery pretty routinely, and the healing is minimal. It's not very uncomfortable after the surgery. So I think it's case by case. To make a long story short, if it was a mandibular molar, that's a little more of an invasive surgery, and depending on the depth or how much bone is between the the buccal plate in the root apex, I don't know if that would be the best option there. So that'd be a different response. I may be more inclined to say you may be better off having an extraction from a prognosis standpoint if it's difficult for us to reach that tooth. So there's just a lot of factors involved, but I think both are effective, obviously. And I tend to have the patient make the decision. I try not to make the decision for them, but whatever gives them peace of mind, I think will work. I'm confident that the surgery will work, and I'm confident that the dental implant will be effective.
Okay, there's another question here about perforations. Once you get into a perforation, what do you do?
Sure. So for the perforation, the most important, there's a couple of factors that will affect your prognosis of a perforation. One of them is time. So if you do have a perforation, the best thing to do is to repair it as soon as possible. So if there's a perf, when I say repair, there's a number of materials you can use, from CAVIT to IRM to glass ionomer to something to seal it off as best you can. What I do, if there's a perf, I'll tend to rinse it out with Paradex or chlorhexidine 2%, and then I place Endo sequence BC root repair material. That's the material I use for perforation repairs. That also is the same material I use for my apical surgeries. So when I do an apicoectomy, that's the material I'm going to use as the retrofill. But that material has been very effective for us as well. But the location of the perforation, the size of the perforation, if it's close to the furcation, a lot of those factors, and then the time that it takes to repair, all of those are factors that can contribute to the success of that perforation repair.
All right. Any more questions? Dr. Okpeyemi Okioso, can you hear me? Dr. Okioso, I know you do a lot of endo. I know there's someone here from Kenya. How are you, Shalimo? If you're able to speak, I just want today, if we can, Tariq, where are you from? Go ahead if you want to speak. All right, I'll just try. I don't know if, how do you deal with broken files?
So for a separated instrument, a lot of it depends on the visibility. So if I can see the file, then I have really small ultrasonic tips. I may try to tease it out or to trough around it. That's pretty much about it. If it's beyond the curve, there's really not a lot of chance we'll have it. And for me, there's not a lot of chance of success I have at removing the file. We can increase the magnification on the microscope, and I can oftentimes see the file if I have straight line access to it. But once it's beyond the curve, which many times is where the separation will occur, it's tough to remove. So I'll run General Wave on those cases, and there's some cases, occasionally it will pull the file out. But more importantly, what I'm trying to do with the General Wave is clean around that file. So if I can get my solutions to bypass the file and I can get sealer beyond it, then I'll feel better about it as opposed to leaving everything below that file to create havoc or cause an issue. So we don't throw in the towel, obviously, if that's the case. We'll still run the machine and see if we can get past it or even dislodge it if I can't get it out myself.
So if you are not able to take it out at all, so what do you,
so typically what we'll do is we'll run the General Wave. I'll try to express sealer beyond it, and then I just prepare the patient. If there's a lesion there, we'll prepare them for the possibility of a surgery. And if it's a tooth that's not really a candidate for surgery, we just prepare them for possibility of an extraction. But the lesion is a good barometer for us of healing. If there's a lesion and it's getting smaller, then we're fine. So honestly, I don't care how it looks, as long as I can effectively clean around it and the lesion goes away. I'll be comfortable with that.
I just want us to I want to find out, so just a little quick survey here. How many people use rubber dam? If you use rubber dam, just say yes in the chat. I just want to know, because I know it's, because many people don't like using it. But I just wanted to find out if amongst the panelists, amongst the attendees today, if you use rubber dam, if we just type yes, I'll wait for a few minutes here. Let's see. No, okay. If all of us can, I would have put it in. So we have some questions here. Dr. Jamal, I'm just wondering,
Sure.
do you still have some time?
Yes, yeah, for sure. I'm good.
Okay. So I would like for you to answer the question. Yes, go ahead and just say yes or no, so I will know how many people use rubber dam and so I just a little survey for my inquisitive mind. I just wanted to ask. So, if you want to speak, I just wanted to get somebody to just respond, if you don't mind, please. He says, from what he just talked about, what is the goal of root canal treatment? Dr. Jamal, you're going to answer it later on, but I just want to see in terms of, if you were, as you listened to him in his talk, what is the goal of, and if you want to speak, if you want to speak, just let me know. I would allow you to speak. And if you are able to speak, just go ahead. Just let me know. If you want to type it in, if you're more comfortable with typing it in terms of what is the goal of root canal treatment. I know this is like, so we're supposed to have like these post-test questions. I wanted to give, I don't think we had like the answer options where you could pick from. So if you want to go ahead and if you would like to speak, I know something, Awudu, Dr. Ochua Awudu, I'm sorry, you are my friend, so I think I can pick on you. Ochua, I'm going to give you an opportunity to speak. All right, Ochua, the floor is yours. Can you hear me?
I can hear you. Good evening, Dr. Uvoh. Can you hear me?
Yes, go ahead. Yes, I can hear you. So what's the goal of root canal treatment?
Okay, so basically, to gain access to the root canal space and clean, debride, remove all bacteria as much as possible and fill it up again. As he said, the focus is more on what goal can take, not what we eventually fill the root canal space with. So in an infected root canal, we need to make sure we get maximum cleansing of the canal decontamination, and then we buy an inert material to fill it up, and then of course put in a proper extracoronal restoration or even an intracoronal one as the case may be, depending on the amount of destruction we started with.
All right, thank you. That was Dr. Jamal. You're the one that's going to, what was your answer to that question?
Yeah, I think that's great. I mean, the ultimate goal is to make the tissues around that tooth healthy and preserve that tooth. So that's what we're trying to do. We clean it out so we can get the periodontium healthy. We don't want lesions or abscesses or inflammation around it. So yeah, she nailed it. That's what we want to do.
All right. I mean, you had it. You nailed it. All right.
So that we can take care of whatever is left. We want to create an environment where the body can take care of anything that's left behind. We want the body to help you eventually.
All right. Thank you so much. Anyway, this has been an interesting time. Dr. Kyoso, if you are there, I wanted to just get a comment in terms of what you guys use in your Dr. Umuna, Anthony Umuna, Palacio, are you there? If you are there, if you want to speak, your microphone, you can turn it on and I will hear you. But guys, thank you so much for coming, for today's webinar. Dr. Jamal, thank you so much. Thank you so very much. This has been the most interactive webinar we've had in 3 months.
Oh, awesome.
In 3 months. I've done this for 3 months, and this is one where, people want to talk and talk about, I think it's something that, they experience on a daily, on their, daily work basis. So Endo is what most people do. And it seems to be a very, popular amongst attendees. Thank you so much. But I want to let you go. I know you have other things to do. Thank you so much for coming. And we're going to have the recording available on YouTube later in the day, so at least you can, catch up, and listen. You can rewind it, and and get all the details. But thank you, thank you. Next weekend, please join us, and we're going to have an exciting time with Dr. Mazal.
Thank you for having me.
All right. Okay. Bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator